blood supply, blood vessels, and drainage. These are short answers. You could see them as multiple choice questions as well. So, which of the following veins join together to form the superior vena cava? A, B, C, D. Right. So I have them here as put them all on one page. As short answers, but it could be done either way. So, what two veins join together to form the superior vena cava? No. Brachiocephalic veins. All right. What two veins join together to form the brachiocephalic? Subclavian and
internal jugular, or the
there's no common carotid vein.
internal jugular.
Internal jugular vein. Okay. So here's the internal jugular vein and the subclavian forming the brachiocephalic on each side, and here the two brachiocephalics form the superior vena cava. Okay. Popliteal vein is formed by the union of the anterior and posterior tibial veins. So here's our popliteal vein. Here's the anterior tibial vein coming in from the anterior aspect. Here's our posterior tibial vein. The two come together, and at that point, we have the beginning of the popliteal vein. None of any of my changes here. I misspelled popliteal.
You still would have got credit. It's only one letter.
One letter. Thank you. Thank you.
Is Greek this small picture?
Yes. Starting right. Well, that's posterior tibial. It's shown right there.
Venus, right? What about the small penis? Does that also go into it?
It goes into the popliteal, but it's not formed by the union.
Okay.
So the question is, it's formed by the union. So yes, it does drain into it. So the three of them drain into the popliteal, but the small saphenous doesn't contribute to the formation of it. So if we go back to this picture, our external jugular drains into the subclavian, but it doesn't form the subclavian. It's just receiving that. Okay, this whoops. Superior adrenal artery is a branch of
The inferior phrenic.
phrenic. So here's adrenal gland, inferior phrenic, middle phrenic, sorry, inferior adrenal, middle adrenal. Here's the inferior phrenic along the diaphragm. The kidneys are really high there, and giving off multiple superior. Name the three branches of the celiac trunk. Left, not colon, gastric. Okay, so here's the celiac trunk. Here's left gastric coming around the small curvature of the stomach. Here's splenic going over to the spleen, and common hepatic or hepatic going over to the liver. Okay. Cephalic vein and basilic vein both drain into the
Antebrachial.
no,
Axillary?
you're going up towards the heart.
Oh, up towards our
Axillary.
axillary.
Okay, so cephalic drains into axillary, and basilic drains into axillary. And then just after cephalic empties into it, it becomes subclavian. Inferior brachial junction, right here. That little piece right there. Inferior rectal vein drains into internal pudendal, which then drains into internal ilia. Okay, you know it now. The portal vein is formed by the union of not inferior, superior mesenteric, and coming over from the left side, splenic. Okay, so here's the portal vein, superior mesenteric and splenic come in to form the portal vein. Here's inferior mesenteric draining into splenic. Deep palmar arch is supplied primarily with blood from what artery? Radial artery. Okay, so here's the deep palmar, radial artery coming into deep palmar between the web space. And ulnar does mostly superficial palmar. The hepatic artery is found with what vein? Portal vein. So here we saw this in Tom yesterday. Here's the portal vein, and right beside it, carrying blood, both of them carrying blood into the liver, would be the hepatic artery. And the hepatic veins are leaving the liver up at the superior aspect to go into the inferior vena cava. So we don't have our hepatic vein beside the hepatic artery like we typically do with most other vessels. The fibular artery is a branch of posterior tibial. So here's popliteal, giving off the anterior tibial and the posterior tibial, and here's fibular. Okay, so it's a branch of posterior tibial and the reverse fibular vein drains into posterior tibial. Dorsalis pedis vein drains into
Anterior tibial.
anterior tibial, and actually it is connected to great saphenous, so you could go either way.
Small saphenous.
The lateral aspect of the foot and ankle would be drained by the
Small saphenous.
small saphenous. Okay, so here's the small saphenous starting on the lateral aspect of the foot, goes midline and empties into the popliteal, just on the back of the knee. You guys impressed with how much you've learned already? Okay, so then as much as doing review, I'm trying to exemplify for you how to think through the questions. Okay? Oh, I saw that one. So here's a table. You will have a table not exactly like this, but similar to this. It looks scary. But you know a lot of this information. So again, I want to take you through how to think about it. So the directions are, all the changes, any of the changes in column 1 would have what effect on the characteristics or events of column 2. So on the test, you would mark increase, decrease, or no change. Okay? So a decrease in the number of cyclic A and P molecules in the cell would have what effect on the number of open funny channels? Decrease. See how easy that was? Now we can only take the test together. Okay. An increase in the cyclic AMP would have what effect on the membrane potential? Would make it increase it in positivity or decrease it? Increase. Okay? An increase in aldosterone is going to do what to venous return? Aldosterone causes sodium ions to be excreted or reabsorbed? Reabsorbed. And where sodium goes, water is sure to follow. Increase venous return. Okay? An increase in end-diastolic volume. Remember what end-diastolic volume is? The amount of volume of blood in the ventricle when the AV valves close is going to do what to end systolic volume? It doesn't make the heart pump out more, it just makes the heart pump harder, so we're back to status quo. So yes, stroke volume would be greater. It does make stroke volume greater, but the same amount of blood is left in the heart. Does that make sense?
Yeah.
Okay. We can make the stroke volume even greater with additional norepinephrine or something like that, but if it's just the stretching of the heart wall, that just brings it back to its normal volume it would have had in the first place. Okay?
Is end-systolic always the same?
Pardon?
Is end-systolic volume always the same?
Well, not if we change stroke volume. So if we increase stroke volume, then end-systolic volume will decrease. Okay? Remember the chart I had on the PowerPoint slides yesterday, and I put those modified ones up this morning? So we can have a greater stroke volume and still have the same amount of blood left in the bottom. We have to add some additional change to that. All right, an increase in the PR interval is going to do what to stroke volume? Increase ventricular filling, increases stroke volume. Okay, so it's kind of looking at this from the other side. Again, if I'd had end-systolic volume, it would be no change. But the stroke volume is going to be greater, because an increase in PR interval is going to result in an increase in end-diastolic volume. Longer period of time for the heart to fill. An increase in norepinephrine will have what effect on intracellular calcium ions?
Increase.
Increase. It opens channels both into the cell and from the sarcoplasmic reticulum. An increase in intracellular calcium ions are going to have what effect on cardiac output then?
Decrease.
An increase. So this is going to increase
Heart stroke.
The stroke volume,
And
and with the same heart rate, even if we don't increase heart rate, you're still going to have an increase in cardiac output. A decrease in acetylcholine release is going to have what direct effect on ventricular contractility?
decrease.
None. Good job. Why?
No
There are no receptors. Indirect effect, yes, because an increase in acetylcholine is going to mean a longer rest period, therefore a greater filling. But remember I said I want you to answer it for the way the question's written. There are no receptors for acetylcholine on the ventricle contraction. It would change the PR interval, but it's not going to directly affect ventricular contraction. A decrease in stroke volume with an increase in heart rate. Good.
It's not actual.
Section 1 didn't like me for this question this morning. Now, if I only had a decrease in stroke volume, then there would be a decrease in cardiac output. If I only had an increase in heart rate, then there would be an increase in cardiac output. But here both happened. The reason both happen is to keep the status quo. Obviously, they have to happen to the same degree. Okay, so if our heart rate decreases to 50 and our stroke volume increases to 100, cardiac output is still 5 liters. Okay. There's another spelling change. I changed it. It didn't work. Increase in digitalis. What's it going to do to intracellular calcium?
Decrease.
Increase. A decrease in viscosity. What was viscosity? The thickness of the blood. So if we have a decrease in viscosity, that effect would be
Decrease.
a decrease in peripheral resistance. And an increase in extracellular potassium ions.
Decrease.
It's going to decrease, no.
Increase.
Yeah, it's going to decrease conduction. It's going to increase the time. Decrease the conduction. Last thing. Oh, I'm sorry. It's not gone forever. They actually got mad at me this morning when I changed it to it's like, I'll go back. It's not like completely eliminating the slide. Yay. Okay? All right, so last thing up here is a tracing question. And this is what the tracing question extra credit ones will look like on they'll be longer than this. Because I think I have 14 blanks and they're each worth half a point. So notice as we go through, however, that I give you some checkpoints along the way. To let you know, okay, I'm on the right path, or this is the way I'm supposed to go. So trace the drop of blood from the anus or external anal sphincter to the occipital lobe. We're talking about the brain here, so I think I know that has an occipital lobe. So we start out with the external anal sphincter, and we're doing veins. From means we start out with veins, okay? So don't make that mistake and go to arteries first. We're going back to the heart. So, external anal sphincter, what carries blood away from the external anal sphincter?
Inferior rectal.
Inferior rectal. Internal pudendal.
Internal iliac.
Internal iliac. Now, if you left one of these off, let's say you would put inferior rectal and then you went to internal iliac and then to external iliac. I would give you credit, doesn't? But people do it. I would give you credit for the internal iliac. I don't take away points. So just because you put a wrong answer, I won't subtract points from the ones you got right. Does that make sense? Okay, so I would give you credit for the internal iliac. It doesn't have to be on line 4. You could put it on line 2 and 3 and 4 be wrong. I would still give you credit for at least having internal iliac in there.
So wrong answer and blank is the same.
Yes. Okay? So I don't subtract points from the ones you earn. You just don't earn anything for it. All right, so from the common iliac, then, it's going to go into the inferior vena cava. And I typically put heart. Now, there might be a situation where I want you to trace it through the heart, but I typically will put the heart there. That means you don't have to go right atrium, left atrium, pulmonary veins, arteries, whatever. That's all taken care of, and now we're leaving the heart. And so, pardon? Yes, now we're arteries because we're leaving the heart. So we leave the heart via the
Ascending aorta.
ascending aorta, aortic arch, brachiocephalic trunk. So that tells you we're going right, okay? So now we have two ways of getting to the brain.
Common.
Internal carotid arteries and vertebral arteries. Both will take us into the brain.
What's fastest?
So here we're looking at posterior communicating artery. What does that make you think?
Vertebral.
Posterior communicating is connecting the both of them. But I want you to go to the occipital lobe.
The
If
middle
we go to
cerebral.
vertebrals, do we need to use the posterior communicating?
No.
No, we would just go vertebral, basilar, posterior cerebral, and you'd be there. So now we need to use the carotids because I put posterior communicating in there for you. All right? So brachiocephalic trunk to common carotid, internal carotid,
Vertebral.
and then how do we get to posterior communicating? Middle cerebral. And then we take the posterior communicating to posterior cerebral, and we're at the cerebral lobe.
So you have like an unlabeled
That's, I'll give you blank pages to put your own picture on. Remember I said to practice those line drawings? Yeah. Okay? Again, there will be 2 tracing ones for extra credit, so a total of 7 points. They're a half a point each, and you can choose one or the other. There will be directions. If you don't choose for me, I will answer the first one. I'm not going to grade them both and give you credit for the one that has the most correct answers.
Damn.
So if you try them both and you don't mark which one you want me to grade, I'm just going to grade the first, I'm going to grade letter A. Okay? Got 5 minutes. Anybody have more questions?
Oh, I wanted to do another one of those.
Well, we can.
Okay, let's
Don't
do
have
it.
one written up. Want to do another tracing question?
Sure.
Anybody have any other tracing drop of blood? Do you have ideas?
Your big toe.
Top of the big toe or bottom of the big toe?
Bottom.
Bottom?
To your right thumb.
To your pinky.
Okay. So we start off with big toe. We're on the bottom. Since we're on the bottom, that takes out dorsalis pedis and great saphenous.
Plantar.
Okay, because those deal with the top and the side. So the next one is going to be medial plantar vein. And medial plantar vein is going to bring into the,
Great saphenous? No?
Nope.
No.
we're done with saphenous, we have to go deep veins.
Oh, sorry.
Posterior tibial,
Go, Lisa.
posterior tibial is going to carry blood into popliteal. That will change name as it passes into the adductor magnus.
Femoral.
That will cross under the inguinal ligament and become not common yet,
Pedental.
external,
Oh,
and
iliac.
then
Okay.
that will become common. You know how to spell.
I don't judge spelling.
And then heart. Leave the heart through the aorta. Do the arch first. And right thumb to brachiocephalic.
Axillary.
The Flavian artery.
Axillary.
Axillary artery.
Why do I say axillary?
Because that's how you spell it. Probably that's how you spell it.
And then right thumb is
Brachial.
going to be
Brachial.
radial artery.
So,
And then if I had another blank there, you could just leave it at that, if I have
stops
another
here,
blank
then you
there, what
have
would you
this.
put?
You missed it.
What about brachial?
Oh, you're right, you forgot something too.
I was like, oh, it jumped.
Deep palmar.
Brachial artery,
Put brachial vein yesterday.
and then radial artery,
Deep palm.
and then the palmar arch.
And then the digi, whatever.
And then, yeah.
Is it the
Or
ulnar?
I might just
Isn't
leave
it
it at
the
that and
ulnar?
put, there was a blank there, we digital, but, or I could just put right.
Isn't it the ulnar?
Oh, no, thumb is radial.
Okay,
Radio
We're
antenna,
looking in the.
right?
or put digital.
Ulnar is pinky.
Oh.
So then that would have been the
Yeah.
superficial.
When would you use cephalic and like?
Okay, that would be drainage. So if I say drain a drop of blood from the back of the hand, then dorsal venous arch, or I might put dorsal venous arch there for you. If I say the back of the thumb, that tells you it's going to be cephalic and not basilic.
Yeah.
All right, so then you would go cephalic. You could stay cephalic all the way up to axillary, or you could cross through median cubital to basilic. So if I put one of my blank lines in there with median cubital, then you'd have to cross over to the other side.
Does the arch not take it to the other side of the?
It may or may not, it just depends. I mean, it can only go one direction at a time. Okay? Yes.
On the study, Joseph has a question about chemoreceptors. Did you say we're not?
Yeah, so chemoreceptors and baroreceptors affecting blood pressure. There was a few slides in there that I deleted from what I modified and put up online. We'll deal with it when we get to respiratory. Yeah, so whenever your heart needs to have better circulation, if you have too much CO2 or too many hydrogen ions, that kind of stuff, but I won't have anything directly on that. And I took out the slides that dealt with all the factors on the endothelial capillaries, like the nitrous oxide we talked about with the penis. So, oh, the one thing I did mention to the morning class, we didn't go over the pathologies of the heart. We talked a little bit about, pyramidal valley and so on. But I did want to mention congestive heart failure. All right, congestive heart failure causes congestion, causes edema. And we talk about right-sided versus left-sided. So again, this is a matter of not memorizing, but figuring it out. If the left side of the heart is weak, then where does the blood come from that goes into the left side of the heart?
The right ventricle.
Comes from the lungs. So it's going to back up into the left atrium if the heart's not emptying completely, and it's going to back up into the pulmonary veins. Then it's going to back up into the lungs where we have the pulmonary capillaries, and that higher pressure is going to cause fluid to accumulate in the alveoli of the lungs, resulting in pulmonary edema. Now, it may keep backing up and result in right-sided congestive heart failure, or you could start out with right-sided congestive heart failure. So the ventricles,
Would that be pretty much that question for?
yeah. So the ventricle, the right ventricle, then, if it's not capable of keeping up with the inflow, it's going to back up into the right atrium, and that will back up into the superior and inferior vena cava, and then into the systemic capillaries, and you have swollen fingers and swollen ankles, and you have systemic edema. So just follow where the blood is coming from, and it's going to back up in the reverse order. So left-sided congestive heart failure results in pulmonary edema, fluid in the lungs. Right-sided congestive heart failure results in systemic edema, fluid in the interstitial tissues of the upper extremities and lower extremities. Okay? You can figure